So this is the second part of Krok 1 2016 booklet. Krok 1 2016 booklet. So let's just begin. A 16-year-old adolescent is diagnosed with hereditary UDP. Hereditary UDP. That's uridine diphosphate glucuroniltransferase deficiency. Who can tell me the function of this enzyme? Who can tell me? Who knows? The function. Do you remember what I talked about? Conjugation? Yes. Inside the liver, we have this enzyme that helps to conjugate bilirubin. So that's one of the functions of this enzyme. So now over here, we're having what? A deficiency of that enzyme. Deficiency of that enzyme. Lab tests revealed hyperbilirubinemia. That means too much bilirubin. But the question is, which one of them will be most abundant? Which one will be increased? Is it conjugated or unconjugated? And your answer is unconjugated. Exactly. Unconjugated bilirubin. Why? Because of the deficiency of the glucuroniltransferase. This enzyme is used for conjugation of bilirubin. All right. A 60-year-old patient with a long history of atherosclerosis, thickening of vessels, okay, and a previous myocardial infarction, again, thickening of the coronary artery, coronary artery can lead to what? Occlusion of blood flow, which of course can cause myocardial infarction. And they said this person also has what? A previous MI. And of course, it's interesting to know that it is because of what? The atherosclerosis. So this person is developing what? A retrosternal pain. 3 days later, the patient was hospitalized and then died of cardiovascular insufficiency, meaning the heart is not able to perform its normal function, which is what? Pumping blood to systemic circulation. Now, during autopsy, a fibrous depressed area with about 3 centimeters with clear margins was found within the area of the posterior wall of the left ventricle and the interventricular septum. The dissector considered these changes to be what? So, of course, you are having a history of atherosclerosis, myocardial infarction, and you know myocardial infarction normally affect. So, which part of the ventricles? Hey, I've already said the answer. I want to say which part of the chambers does myocardial infarction affect the most? And of course, you are thinking of where the pumping is, which is what? The left ventricle. So they are saying that after some time or during autopsy, there was what? A fibrous area. And that fibrous will tell you that there was what? A scarring. The normal tissues have been what? Replaced. It has been what? Replaced with a fibrous tissue. So definitely we are having what? A scarring. But this scarring is one way or the other is at a specific place. In other words, it is what? It is focal. It is not a diffuse. It is focal. And of course, they even told you the dimension of that fibrous area or fibrous tissue that is there. And that is what? 3 centimeters in diameter with clear margins. So again, you are thinking of what? Of a focal cardiosclerosis. Sclerosis means what? Scarring, or the replacement of the normal tissues with a fibrous tissue. So your answer here is focal cardiosclerosis. A patient with hypertension has developed headache, tinnitus, vomiting, that is ringing in the ear. Blood pressure is 220/160. there is facial asymmetry. That means one half of the face. Volitional mobility is absent. Increased tender reflexes. Muscle tone of the extremities on the right. What motor disorder of the nervous system has occurred? What has occurred in this patient? And of course, you are looking at this. So half facial asymmetry. That means one half. Increased tone and the muscle tone of the extremities on the right. That tells you that one half of the body is affected. And by saying one half, we mean what? Hemi. So we have what? Hemiplegia. So your answer here is what? Is B. Paralysis. Just a partial paralysis. Definitely a partial what? Paralysis. Partial paralysis. That is all. So the answer here is what? Is B. Okay. Now, what condition can cause paralysis? Who can tell me? What condition? What condition in the brain as a result of increase in blood pressure can cause this thing to happen? Who can tell me? Anyone?
Can it be a stroke?
Exactly. Stroke. Guys, stroke. High blood pressure can lead to stroke. Stroke. Very, very, very important. Stroke. And there's even a mnemonic for you to classify something as a stroke. And they call it what? The face. Sorry, the fast. Sorry, fast, not face, fast. And the fast means what? Facial paralysis, arm paralysis or problems with the arms, inability to lift the arm or something like that. That's what? A. Then the S talks about what? The speech. The T talks about the time. So this is a mnemonic that helps you to classify or to immediately diagnose a person of having what? A stroke. That's just by the way. You're not yet in final year, but if you're in final year, you understand this better. Okay, so the answer is B. A 7-year-old child in the state of allergic shock caused by a bee sting has been delivered into an emergency ward. High concentration of histamine was observed. Production of amide was the result of the following reaction. In other words, what causes the activation of this histamine, for it to cause allergic, or for it to start leading to bronchoconstriction and vasodilatation and stuff like that? What is the mechanism of action? And of course, we are looking at what to call what? Decarboxylation. So when biogenic amides undergo a process called decarboxylation, they become sort of what? Activated. They become activated to start causing what? Problems. They become activated to start causing what? Problems. And of course, the enzyme is called histidine decarboxylase. So the answer here is what? Decarboxylation. All right. A 26-year-old woman consulted a doctor about having stool with white, flat, moving organisms resembling nodules. I believe some of you know this already. Laboratory analysis revealed proglottids with the following characteristics. They are long, narrow, with a longitudinal channel of the uterus, 17 to 35 lateral branches on each side. What kind of intestine parasite was found? What was found? And of course, you are looking at what? Taenia saginatus. And this is simply a form or a type of what? Tapeworm. And how do you differentiate? Now, there are two basic types or species. We can talk about what? The Taenia solum and Taenia what? Saginatus. So let me just give you one or two things to differentiate between them so you don't get confused. Okay. So all of them are tapeworm anyways, but Taenia saginatum has 13 or more uterine branches. I repeat, Saginatus has 13 or more uterine branches, 13 or more, whilst Taenia solium has 5 to 12, 5 to 12, 5 to 12. So please, this is one of the key things that can help you to differentiate between solium and saginatus. And over here, we're having what? 17 to 35. And we are saying that it should be more than what? 13. So obviously, your answer should be what? Should be saginatus. So please take note of these differences so you don't get confused. All right. A man is 28 years old. Histological investigation of the cervical lymph node revealed a changes of 8 pattern due to proliferation of epithelioid lymphoid cells and macrophages with horseshoe-shaped nuclei. And then in the center of some cells, there were non-structured light pink areas with fragments of nuclei. What disease are these typical of? What disease are these things typical of? And over here, we are looking at what? A horseshoe nuclei. And this horseshoe nuclei is specific for TB or tuberculosis. TB or tuberculosis. TB or tuberculosis. So basically, they have this big, giant what? Cell. This big, multinucleated giant what? Cell that resemble the shape of a horseshoe. In other words, clusters. They are more like clusters at the pole. Clusters at the pole. Clusters at the pole. But this one, they are mainly found at the periphery, but sometimes they can be found at the center. Okay. Sometimes they can be found at the center. Like in this case, they're actually found at the center, but mostly you can find them on the periphery. The periphery. The periphery. So again, horseshoe should help you with your diagnosis. Horseshoe should help you. Of course, Hodgkin's, you are thinking of what? Reed-Steinberg cells. Reed-Steinberg cells. And of course, syphilis, you are thinking of what? Guma cells, if you guys can remember. Guma. So these are all things that I think we talked about when we're dealing with granulomatous what? Processes. All right, so over here, we're looking at what? At A as our answer. Sex chromatin was detected during examination of a man. Guys, look, a man's buccal epithelium. A man. Sex chromosome detected in a man's buccal epithelium. What are we looking at for? This is a man. And we're looking for what? A sex chromatin. A man. And we're looking for what? A sex chromatin. What it means is that, so in fact, before I begin, who can tell me the genotype of this man? Genotype of this man would be what?
47XXY.
Exactly. 47XXY. Exactly. 47XXY. This is a man with an extra X. This is different from what? XO, where the chromosome did not separate. So there's no bar body, no bar body, no bar body. But over here, we are having an additional one, sex chromatin. Sex chromatin. So please, we are looking at what? At this person having what? 2 bar bodies, an extra bar body. An extra bar body. So over here, we're having what? XXY. And that's the same as what? Klinefelter syndrome. Klinefelter syndrome. Down is 21. Tenor is XO that I just wrote over here. Then triple X is, of course, the name implies triple X. Triple X. All right. So the answer is what? Is A. Autopsy of a man with tuberculosis revealed a 3x2 large cavity A 3/2 large cavity in the superior lobe of the right lung. The cavity was interconnected with the bronchus. Its wall was dense and consisted of 3 layers. Internal layer was pyogenic. Middle layer was tuberculous granulation tissue. Tuberculous granulation tissue, and the external one was made of what? Connective tissue. What is the most likely diagnosis? So without wasting my time, you definitely know that we are having a case of what? TB, tuberculosis. So now, based on the description, we have to determine what type of TB is it. What type of TB are we sort of looking at for? What type of TB? And over here, we are having, of course, tuberculosis is here. A 3/2 cavity. They revealed a 3/2 cavity. Now, in tuberculosis or in medicine or disease like they want to talk about cavity, we are referring to what? Either a cyst or you are referring to what? A cavern. A cavern. A cavern means cavity. A cavern. We are referring to what? A cavern. Cavern. That is what comes to our mind. That will come to our mind. So now we know that we're doing what? With a cavernous type of what? Tuberculosis. But again, what type of cavernous? Now let's continue. They said this person is having what? The wall is dense and consists of 3 layers. It's having what? Sorry, before that, they said this cavity was interconnected with the bronchus. Good. And each layer has what? 3 layers. The internal layer was pyogenic. Middle layer was tuberculous. And the outer layer was made of what? Connective tissue. Connective sort of what? Tissue. And over here, we are definitely looking at what we call what? Fibrosis or a fibrous kind of what? Tissue. A fibrous kind of what? Tissue. A fibrous kind of tissue. And that's what over here we are looking at what? A fibrous cavernous tuberculosis. Cavernous tuberculosis. Cavernous tuberculosis. So please take note of that. So over here, your answer should be what? Should be D. Your answer should be D. Should be D. All right. Patient having suffered from a thermal burn, that means heat burn, developed painful boils that is filled with a turbid liquid in the skin. A turbid liquid in the skin. What morphological type of inflammation has developed in this case? What morphological type has developed in this case? Now, again, I believe it's over here that I talked about exudate and a transudate. So we say exudate is as a result of what? Inflammatory process. What's a transudate is as a result of what? Any other thing apart from inflammatory what? Process. For example, increase in pressure in the vessels can cause leakage of fluid from the vessels into the interstitium. And that is also called what? A transudate, not an exudate. So over here, we are definitely going to be dealing with what? An exudative type of what? Inflammation. So the question is that what type of exudate are we looking at for? Now, the question says we are having what? First of all, before I continue, I think I said it over here. Before I continue, what is the color of a serous, how do you call it? Inflammation. Who can tell me?
Yeah.
It's what? I can't hear you.
Clear. Transparent.
It's clear. Someone say something else. It's clear. Serous means the exudate is clear. Okay. Exodus. Exodus. The exudate is very what? Clear. Okay. Now, croup and diphtheric means the exudate has what? A fibrinous type of what? Tissue there. Fibrinous, and of course, we know fibrinous, Cropos, diphtheric. How do you differentiate between them? One can easily be removed, other cannot be easily be removed. So please, if you're confused about this kind of inflammatory process, do watch our videos. Do watch the basis. Do watch the basis. But basically over here, we want to talk about boil that is filled with a turbid liquid. Now, when we talk about turbid liquid, we're referring to a liquid that is also what? Clear or watery, or the exudate resembles the serum. So either it resembles the serum, or it is clear, or it is what? Watery, or it is what? Turbid. They all mean serous. They all mean what? Serous. So over here, definitely, we are looking at for what? For a serous type of what? Inflammation. Now, what about if the fluid is made of mucus? Mucus. Who can tell me the type of inflammation it is? Mucus. A lot of mucus. So you are dealing with what? Catarrh. Catarrh. Have you heard of catarrh? So patients come to us, complain of catarrh. We ask them if they bring things out, if they bring flames. These are sort of what? Mucus. So the kind of inflammation they will produce, we call it what? A catarrh type of what? Inflammation. A catarrh type of what? Inflammation. And that is why over here we are looking at what? At A as our answer. A as our answer. Aren, more. Guys, a minute. Sorry? No, I thought I was teaching now. Because I was about to start. Great. So let's move to the next thing. Sorry for that interruption. A 7-year-old child has acute onset of disease. Acute onset of disease. Temperature up to 38, rhinitis, cough, lacrimation, large spot rash on the skin, pharyngeal mucosa is edematous, hyperemic with whitish spot in the buccal area. What kind of inflammation caused these changes? What kind of inflammation caused these changes? First of all, people come to our department. In fact, I just mentioned it a few minutes ago. People come to us with this kind of, oh, I'm having a runny nose, I'm having cough, my this is this, then that, and that. So, guys, what are you talking about? Catarrh. Exactly. So you are thinking of what? A catarrh kind of what? Inflammation. Don't be confused with the fact that they are what? They are whitish spot. Okay, don't let this one confuse you to think that maybe it is a fibrinous. Because fibrinous too, they are sort of, they come with something similar with, because the fibrin is more or less like something like white. Sometimes we can see this kind of thing there. But this is more of what? A catarrh than a fibrinous, okay? It's more of catarrh than fibrinous. So over here, we're looking at what? A catarrh type of what? Inflammation. A catarrh type of inflammation. And again, they put two types of what? Mucus. All right. After a traffic accident, a 36-year-old patient has developed muscle paralysis of the extremities on the right, lost pain and thermal sensitivity on the left, partial loss of tactile sensitivity on both sides. What part of the brain is the most likely to be damaged? What part of the brain is damaged? So now, look at this. Always use pain and temperature as your reference point when it comes to questions like this. Okay, use pain and temperature as your reference point. I repeat, use pain and temperature as your reference point. Why am I saying that? Because now, assuming this is your spinal cord, okay? Guys, I'm not good with drawing, so forgive me. Assuming this is your spinal cord. This is not a heart. This is somebody's spinal cord. This is, it's even funny. This is Faustina's spinal cord. Faustina is your spinal cord.
No.
So assuming this is Faustina's spinal cord. Okay. Now, wait, is it how spinal cord is like? No, I don't think that spinal cord is. I think it's something like this.
Please, my spinal cord is not like that.
Please, it's like this. Your spinal cord is like this. Whether you like it or not, it's like this. We have concluded. This is spinal cord. Good. But back to business. So, assuming this is your spinal cord. No, not assuming. This is Faustina's spinal cord. Now, we have receptors for pain and temperature maybe around somewhere here. Okay. We call it the the lateral horn, the anterior horn, the posterior horn. I believe you know some of these terminologies. Okay. If you do neurology, that means brain, CNS, you remember some of these things. I know I'm not getting the drawings right, but then just take note. We have the anterior horn, the posterior horn, the spinal, the lateral horn, and all that kind of stuff. Now, when it comes to pain and temperature, even though the pain is developed over here, but it comes here. So it is contralateral innervation, then it goes to the brain. So they cross over before they go to the brain. So if this is happening on the left side of your body, it actually means that inside your brain is occurring where? On the opposite side. I hope this is the easiest explanation I've seen. Yeah. If pain and temperature is occurring on the right, it means the sensation is coming from the left side of the brain. And if you are feeling the pain and then the temperature on the left, it means it is coming from where? If it's on the left, it means it's coming from the right side of the brain. Right side of the brain. Great. So over here, what is your answer? We said there's loss of pain and thermal sensitivity on the left. So guys, what is your answer? Based on explanation, what's your answer?
Right hand side.
Right hand side of the spinal cord. Exactly. So over here, your answer is what? Right hand side. That is what? D. Again, always use pain and temperature as your reference point. When there is pain and temperature there, use it as your reference point. So this is a contralateral sort of innervation. All right. A 4-year-old child has been admitted to an orthopedic department, we say orthopedic, bones department, with a displaced shin fracture. I think we have discussed this before. Bone fragment repositioning requires analgesia. What drug should be chosen? Yes, what is your answer? Promedol. Exactly. And we have talked about this countless number of times, that even though there's morphine, which has the highest form of pain relief, but in cases like this, we normally use what? Promedol is preferred. Promedol is preferred. So please don't go and confuse yourself. All right. Representatives of a certain human population can be characterized by elongated body, height variability, decreased volume of muscle mass, increased length of the limbs, decreased size and volume of the rib cage, increased perspiration, decreased indices of basal metabolic, I think it's not about basal metabolic and fat synthesis. What type of adaptive evolution is it? A lot of people have been calling me for this kind of question, but look at it. We are having a case of what? Elongated body. If you have seen Firstly.
Oh,
guys,
Baha, leave me alone. No. Oh.
Faustina is my baby, so anytime I have to worry her. But she's very tall. She's very tall. Where is Arabina? Arabina is not here today.
She's short, please.
I know she's short. So elongated body, like my dear Faustina. Those who know Faustina, after here, just ask her to let you see her, okay? She's a very kind person, so I'll allow you to see her. Elongated body, height variety, decreased volume of muscle mass. She knows what I'm talking about. Increased length of the limbs. Decreased fat. Which part? Which part of the body is fat? Decreased size and volume of the rib cage. Increase in perspiration. decrease in basal metabolic rate, and fat synthesis. They don't even have the fat, so stop talking about fat synthesis. They can't synthesize any fat. So what type of adaptive evolution is it? Guys, I don't know how to explain this, but this, so Faustina, this is you, and you are what? Tropical. You are tropical. Guys, tropical kind of person. So don't confuse yourself with Arctic, which more of this people deal with people with in cold weathers. Like, say Arctic. People who are in the cold temperate zones, okay? Very, very cold temperate zones. So their sort of mobility is kind of what? Different. The intermediate, the moderate type of people to, people like us who are a little bit muscular. Okay. You people have not seen a Radial before, but Radial is a little bit, with a little bit flesh, somehow short. We have to give her a chair to stand on to pick something from the top. Anyway,
Wow.
So, hey, she's here. Hey, I'm there though. She's not here. Oh, so you are short. Don't mind me. It's a slip of tongue. Okay. I'm here for you. Don't report me. Report me to Rabina. I will deal with you. So please, over here, we are doing what? Tropical kind of people. And of course, those who go on mountains, Charlie, their heart is big. Their heart is just big. Their chest is very broad. Why? Because, Charlie, they want more air, more oxygen. Because as you go, oxygen is less. Hope you know that. Do you guys know that as you climb the mountain, oxygen level is decreased?
Yes.
Anyways, higher altitude, decrease oxygen. So that's just by the way. Anyways, so over here, we're talking about what? Faustina. So even if you don't remember this question, just remember my wife, Faustina. While examining the foot's blood supply, a doctor checks pulsation of the large arteries running in the separate fibrous channel in front of the joint between the talocrural areas, between the what? This was the talocruralis. What am I saying? The joint of the talocruralis and the tendons of the longus extensor muscles of the hallux and the toes. I don't know what I didn't say. What artery are they talking about? In other words, what artery is profound in the mid-anterior foot? The mid-anterior foot. What artery is profound in the mid-anterior foot? The mid-anterior foot. If I were you, I'll just start putting my hands over my anterior foot area. And over here, you are going to look at what? The dorsalis pedis. The dorsalis pedis. Dorsalis pedis. So on top of your foot, both feet, okay, on top of it, the largest or the profound, how do you call it? The profound artery that you can find around that area, you are thinking of what? The dorsalis pedis. And again, I will let our tropical lady help us with with a diagram. So over here, you're looking at what? Dorsalis pedis. So let us see the dorsalis pedis, okay? Dorsalis pedis. Put it on the Telegram page. Dorsalis pedis. All right. So the answer is E. All right. 59-year-old woman has been hospitalized in a surgical ward due to exacerbation of osteomyelitis of the left shin. Blood test, leukocyte is 15. Leukogram, myelocyte is 0. Metamyelocyte, 8%. Staph neutrophils, 28. Segmented, 32. Lymphocyte, 29. Monocyte, 3%. Such blood count would be called what? So anytime there's what? Excessive sort of what? Infection. Don't forget, they say what? Exacerbation has occurred. exacerbation has occurred. And that's why they took the person to a surgical ward. And anytime there is an increase in infection, what happens to the blood? What happens to the blood? You begin to realize that a lot of blood cells begin to what? To be produced, especially the neutrophils. The neutrophils or the white blood cells will begin to what? Increase in nature. Why? Because they want to attack the place of what? Of infection. And of course, we have, I think I talked to you guys about the left shift and then the what? The right shift. The left shift and then the right shift. When we say the left shift refers to an increase in the number of immature leukocytes. That is left shift. A lot of immature leukocytes in the peripheral blood. Basically, the neutrophil, particularly the neutrophil band cells. Neutrophil band cells. Very good. Now, band cells, some books refer to as what? As stop neutrophils. Okay, band cells, stop neutrophils, these are all the same thing. So when there are a lot of them over there, we're basically thinking of what? Immature, a lot of immature, and that's what? Left shift. However, under the left shift, we have what we call what? The regenerative or degenerative. We have what? Regenerative left shift. Regenerative what? Left shift. What does it mean? What does it mean by regenerative left shift? Regenerative left shift is simply used in the context of neutrophilia with a left shift. Neutrophilia with a left shift. Again, don't forget, I said anytime there is increase in leukocyte, which means WBCs. Anytime there is increase in immature leukocyte, we call it left shift. I repeat, left shift. And don't forget, leukocyte could be lymphocyte. It could be what? Neutrophils. It could be anything. Take note. Now, when we say regenerative left shift, we are referring to the part that has a lot of what? Neutrophils. Neutrophilia. I hope I'm not confusing you guys. That is what? Neutrophilia. So please take note of that. Now, when we talk about degenerative left shift, what it means about degenerative left shift, obviously we are dealing with what? Neutrophils. But what we are talking about, when we talk about degenerative, it means that we are having an absolute. When we say absolute, the number of immature is too much than the mature ones. I repeat, the number of immature is too much. The number of immature is too much. So please don't confuse any of the things that I've just mentioned. Don't confuse with any of that I've just mentioned. So first of all, let's analyze this question. Now we are having what? Leukocyte. A lot of what? Leukocyte is present. So is it a right shift or a left shift? Who can tell me?
Left.
Left shift. Exactly. Now, with the left shift, we're not going to analyze whether it is regenerative or what? Or degenerative. And we are saying that in regenerative, there are a lot of what? Immature. However, the immature is not too much more than the mature ones. Now, if you look at the blood analysis, we have stop neutrophils, which naturally means band neutrophils. Then we have what? The segmented. These are actually the matured neutrophils. That's what we found. So we have a lot of neutrophils, but they're not immature. Sorry, they are immature, which is 28%. Then mature is 32%. Now we said in degenerative, the staph neutrophils should be excessively more than the segmented or the matured ones. In this case, what type of generation that we have? Is it regenerative or degenerative? Who can tell me?
Regenerative.
Regenerative. Exactly. Ahmed. Exactly correct. So this is what? Regenerative left shift. Regenerative left shift. Guys, I've taken my time to make sure I remove every confusion. Because I remember the last time that we did it, the understanding wasn't clear. That's why I've taken my time to make sure I bring the explanation out very well for you. So please don't confuse any of it. And anytime there's what sort of inflammatory process, mostly left shift will start happening because leukocyte will increase. A 41-year-old man has a history of recurrent attacks of heartbeats. That's what paroxysms, that is suddenly, or they occur sharply, something like that. Profuse sweating, headaches. Examination revealed hypertension, hyperglycemia, increased basal metabolic rate, tachycardia. These clinical presentations are typical for the following adrenal pathology. So guys, on the adrenal gland, the inner layer is called what? The medulla. The outer layer is called what? The cortex, isn't it? So we have the cortex. The inside, we have what? The medulla. So which part regulates all these profuse sweating, headaches, hyperglycemia, increase in basal metabolic? What part controls? Is it cortex or the medulla?
Medulla.
The medulla. Don't forget the cortex. The cortex deals with what? 3 layers. We have the aldosterone in the first layer. That's the glomerulosa. We have the cortisol in the second layer. Then we have the what? The sex. That is so this is what? GFR. Glomerulosa, fasciculata, reticulata. Or reticularis, sorry. Reticularis. There's sometimes too much information. It gets confused. So basically, this is what? Aldosterone system, where there'll be too much of what? Sodium, cortisol. You already know cortisol. Of course, sex hormone. You know them. So please, over here, you're doing what? The medulla. Because the medulla deals with what? Catecholamines. Catecholamines, which is what? Adrenaline, the noradrenaline, or epinephrine, the norepinephrine. That is where these are produced. So what is the disease if excessive amount of catecholamines are being produced? What is the name of the disease? Come again? Your line is breaking.
Do you mean a tumor?
Cushing disease, maybe.
No. Cushing. Where is Cushing coming from? Cushing deals with what? Cholesterol. Cortisol. But we're not talking about cortisol here. So like someone was saying, we are dealing with a tumor.
Pheochromocytoma.
Yes, pheochromocytoma. That is the right diagnosis. Pheochromocytoma. So please don't forget that. Pheochromocytoma. Of course, hyperfunction of the medulla. Hyperfunction of the medulla. Because there's increase in epinephrine and non-epinephrine and all those. So everything is is increasing anyhow. So please take note of that. Take note of that. During autopsy of a man who died of acute transmural. Transmural means all the layers of the heart. So from the endometrium, myometrium. Hey, what are the layers of the heart again? Look at the layers of the heart. Me, I forgot to know. I hope I'm correct, though. Guys, am I correct?
Metro, metro, and endometro.
Okay. So please, me, I've forgotten, but I think you are right. So the endometrial lining, no, endometrial has to do with uterus.
Please,
Or is
that's
the
the
same thing?
womb.
You say?
That's the womb, the mitral.
Exactly. So I'm talking about the heart. What are the layers of the heart? You should remind me.
Cardial.
Oh, thank you. Guys, I think I need pampering. Someone should pamper me. You will not pamper me. Faustina will not pamper me. You will not pamper me. O2 will not pamper me. O2 will just be there with a table learning. Anyways, so transmural means all the whole heart layers are affected, are undergoing what? Infarction. Now, the following has been detected: fibrous, whitish, brown deposit. Fibrous, whitish, brown deposit connecting the parietal and the visceral pericardial layers. Of course, these are the layers that covers or that insulate the heart. What kind of inflammation are you talking about? Fibrous, whitish. That's why I was saying that even though there's whitish spot on the patient, if you remember, but we can't still go in for that diagnosis. But we're still going for cataract. So over here, what comes to mind? What kind of inflammation is it?
Suppurative.
Come again? Someone is saying serous.
I said suppurative.
Yes, it's not serous. So this is what? Lupus, exactly. Lupus. But the general term is what? Fibrinous type of what? Inflammation. But over here, we'll be doing more of what? The lupus type of what? Inflammation. The lupus, because there's no history of something that cannot be easily be removed. So we can't say this was diphtheric. No. Or there's nothing like bleeding and things like that. So over here, we are dealing more with what? With the lupus type of what? Inflammation. Lupus type of what? Inflammation, which is under fibrinous. So this is what A. A 12-year-old girl developed nephrotic syndrome. So they've told you proteinuria is there, hematuria is there, cylindruria is there 2 weeks ago. Sorry, 2 weeks after a case of tonsillitis. Guys, you already know the diagnosis, isn't it? So first of all, what disease can a case of tonsillitis or a chronic case of tonsillitis have on the kidney? Who can tell me of the disease? Who can tell me the name of that disease?
Glomerulonephritis.
Come again?
Glomerulonephritis.
Come again?
Glomerulonephritis.
Glomerulonephritis means inflammation. It simply means inflammation of the glomerulus. But we are having what? A case of tonsillitis. So you have to modify it. Modify that glomerulonephritis. Modify it.
Nephro.
No. Come on, guys. What? No, immune complex is the type of hypersensitivity. I'm not going to the immune complex. First of all, what causes tonsillitis? What
Infection.
is the infection? But what bacteria?
Staphylococci.
Is what?
Streptococcus.
Streptococcus. So after a case of tonsillitis, and the thing is affecting the kidney, we now have what to call post-streptococcal glomerulonephritis. Post-streptococcal, because strep has caused tonsillitis and immune complexes has formed. And these immune complexes are now being deposited on the glomerulus. And now the cells are not identifying that immune complexes. So it begin to react to it. And that's why we have the infection. Guys, isn't this beautiful? Anyway, for me, it's beautiful. So this is what? Post-streptococcal glomerulonephritis, and that is the name of the disease. But of course, what type of hypersensitivity involve immune complexes? Type 1, type 2, type 3, type 4. What is it? Type what?
Immune complex.
Type
Three.
Type 4.
Type
three.
type
three.
3. Type 4 is cell mediated. Type 4 is cell mediated. Don't confuse immune complex and then cell mediation. Guys, take your time and go through the hypersensitivity again. Okay, so we have type 1, type 2, type 3, type 4. And I think I even told you the diseases under each and every one of them. But please go and look for how the mechanism takes place. Okay, look for how the mechanisms take place. Look for how the mechanism take place. Type 1, what happens? Type 2, what happens? Type 3, what happens? Type 4, what happens? I can recommend Dr. Najib for you, but trust me, Dr. Najib, you will overlearn. I know some of you know Dr. Najib. He's one of my mentors that I always follow him. Very, very, very good teacher. He will go in details and you yourself, you go bore. But obviously, go and watch him if you really want to understand hypersensitivity reactions. Okay? Check him out. So over here, we're looking at what? Immune complexes. This is type 3. Type 3, immune complexes. And again, I remember I mentioned diseases that are under each and every single one of them. Each and every single one of them. Systemic lupus erythematosus forms part of immune complexes. Serum sickness forms part of immune complexes. Rheumatoid arthritis is part of this. Part of it. So please take note of some of these things, all right? A man arrived into a traumatological department, that means trauma department, with a trauma of the right shoulder. If I were you, I'll just put my hand on the right shoulder. That's how it helps me to remember what I'm dealing with. Now, examination revealed a displaced humeral shaft fracture of the right in the middle 1/3 of the humerus. So assuming this is your clavicle and this is your this is your bone. Faustina, how are you? This is your bone.
Please.
This is your bone. So the shaft, this guy talks about what? The body. Or the side of the shaft. That's the shaft. So not that the joint is the displaced thing is not a joint, but the shaft. That's the more like the body. And they're saying what? The middle 1/3. Middle 1/3. So maybe somewhere here. Middle 1/3. Somewhere. If you divide this into 3, 1, 2, 3. So maybe somewhere here. Middle 1/3. Now the patient cannot extend the fingers of the right hand. What nerve is damaged? What nerve is damaged? So over here, you now need to find out what nerve they are actually what referring to. A second. So now let's go for what nerve they are referring to. So normally, if you look at the anterior, the anterior 1/3 of the humerus, majority of the nerve that passes there is the, how do you call it? The radial nerve. The radial nerve. Majority of the nerve passes there is what? Is the radial nerve. Now let me just quickly take you guys through the pathway for the radial nerve. So the pathway of the radial nerve, of course, it starts from the brachial plexus. It starts from the brachial plexus and it goes through the arm, first in the posterior compartment of the arm and later in the anterior compartment of the arm. Okay, and it continues in the posterior compartment of the forearm. So this one here is the arm. Okay, now this is your. So this is your. Before. Fossy. The thing is even funny.
The BAHA, I want my.
Fossy. So guys, look at the anatomy of Faustina's bone. So this is what the arms. For those who don't know what the arm is, this is the arm. This is the forearm. Arm, forearm, arm, forearm. So take note of that. So sometimes that someone said that my arm is paining me, it means this part. My forearm, this part. But when I say my hand, my arm, anywhere it goes. And this is the what? The cubital fossa. That is the cubital fossa. Guys, give me, I'll finish like 10 minutes. That's not my fault. Guys, a second. See. Okay, so Faustina, this is your hand, your arm, this is your what? Your hand, your forearm. Now I'm joining the rest. So we are saying that usually how the radial nerve moves is that it begins from here, posterior, then it comes to the anterior, then in the, how do you call it? Where was I? Then to now move to the posterior again for the, in the forearm. In the forearm. So any injury at any level, any injury at any level would definitely, that place would be, will cause a problem. And over here, they said what there's what? There was a fracture. Okay. And this part was affected. This part was affected. So that part could mean that we are having what? A radial nerve injury. A radial nerve injury. And this radial nerve injury is what innervates about half of the dorsum of your hand. Half the dorsum of your hand. Half the dorsum of your hand. So please take note of that. Take note of that. So please, the dorsum of your hand, half of them is taken up by the radial nerve. So please take note. So if the person, and of course, it moves towards the fingers as well, or the digits as well, or the nail beds as well. So please don't get confused with some of these things. So the dorsum 1/3. So that place could have what? A problem when trying to work with it or extend it and things like that. So over here, we are looking at what? At a problem with what? Radial nerve. So again, Faustina, since this is your own radial nerve, help us with the pathway of the radial nerve. And where there's a picture, there's a picture, there is a blue and there is a is it purple or red sort of thing. I've used that thing before. Just look for radial nerve. You will see where it is innervating. You yourself, you will see where it's innervating. That will be a good picture for this one. All right. And you will see where the medial nerve, where the ulnar nerve, they are all innervating. You will see. So as a way of learning, just get to know the radial nerve, the ulnar nerve, and the medial nerve all together. Okay? Now, work in a mine is known to cause inhalation of large amount of coal dust. Coal dust. Inhaled coal dust can be detected. What it means is that what cells in there can help us know that, guy, there is some problem going on there. And what comes to your mind? Of course, you are thinking of what? The alveolar macrophages. Yeah, we've talked about this before. The alveolar macro. I think it's in 2015 booklet. We've talked about it. Alveolar macrophages. What drug would be the most appropriate for a patient suffering from chronic gastritis? Chronic gastritis. What it means is that there is too much secretion of what? Gastric juice, because it's inflamed. Inflammation of the mucosa. Gastric juice, too much. And you know gastric juice contains in itself HCl, isn't it? Now this HCl is acid, and acid, is not too conducive for the mucosa lining. So the acid begins to destroy the mucosa lining. And that's why we develop ulcer. So this person will definitely develop what? Ulcer. Ulcer. Erosion will take place. Person will develop what? Ulcer. So how do we control this secretion? How do we control this secretion? And of course, you are thinking of what? Gastrozipping, 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 or zippine, gastrozipping. This is the name of drug that is actually used to prevent what? Secretion, or it will antagonize the secretion by the gastric what? Juice, by the gastric mucosa. It will antagonize the secretion. And of course, another name for the gastrozipping will be what? The pyrenzippin, the pyrenzippin, the pyrenzippin. So please, you know of pancreatin, so don't let us go there. You know of pepsin too. But over here, we are dealing more with what? Gastrozippin or pyrenzippin. Pyrenzippin. You know how you pronounce it. We'll move. So over here, we are dealing with what? We are dealing with D. It also helps to reduce muscle spasm in the stomach. A 63-year-old man who has been suffering from chronic fibrous, again, I'm telling you, chronic fibrous pulmonary what? Cavernous tuberculosis. Meaning they were what? Cavern there, isn't it? There were cavities inside the lungs, isn't it? Of course. However, that's not the problem where we are here. The problem is that this person has now been delivered to a nephrology department. That means people who deal with what? With the nephron or with the kidney, with uremia, intravital diagnostic test of amyloid. What are amyloid? We've discussed them. Amyloid are simply what? An abnormal proteins that can be located inside the kidney. And the disease of an amyloid is called what? Amyloidosis. But the question is, what amyloidosis is it? So let me put it to you. Is this a primary type of amyloidosis or a secondary type of amyloidosis? Who can tell me? And why? Huh? Oh, you poor afraid.
Maybe secondary because
Secondary.
Good, because Esther, continue. Because
secondary.
okay,
Because of
Esther,
the 24 years.
because of what?
24 years.
I will lash you.
I think it's because it's a chronic.
Chronic fibrosis.
Because the main problem is not actually the amyloidosis, or the primary problem is not amyloidosis. The primary problem is because this person has already developed a disease. When we say primary means that there is no known cause. Secondary means that there is a known cause. So the reason why there is amyloidosis is because of the fibrinous cavernous pulmonary tuberculosis. Guys, don't forget that. That is why we call it what? A secondary type. Secondary type. So this is not what? Primary. No. And this is not because of old age. So don't go and say this is senile. This is not because of old age. This is definitely what? A secondary. And again, this is not even what? Genetic. Because of this, that's what the person is developing that. That is what? Secondary. Secondary. So over here, we are having what? We are having a C as our answer. C as our answer. So don't get confused. Cells of a healthy liver actively synthesizes what? Glycogen and proteins. Glycogen and proteins. Before I continue, what is the meaning of glycogen? What is the meaning of glycogen?
Glucose.
Yes?
Storage form of glucose.
Fantastic. Storage form of glucose is called what? Glycogen. And it takes place in the liver. And when we have a problem with the storage and its release, what disease do we call it? Oh, I'm saying this to be quick. Now, we're having a problem. Huh?
Glycogen storage.
Exactly. Guys, if I ask question, just give it to me. Quick. Quick. Okay, so when we have a problem in the storage and in the release of it, we call it what? The glycogen storage disease. And we have different types depending on the enzyme that is involved. So you see, you can apply these things. So you are revising, which is good. However, that's not our concern. Our concern is not glycogen storage disease. Our concern is that cells of a healthy liver, of course, synthesize of glycogen and proteins. What organelles are the most developed in them? What organelles are most developed, or what organelles involve even in enzyme, even in protein synthesis? What do you think? What enzyme are you thinking about? Sorry, what organelle?
Endoplasmic.
Endoplasmic. And on the endoplasmic, we have the rough, and then we have what? The smooth, the granular, and the agranular. They all mean the same thing. And at what point do we say that something is granular? It is granular when we are dealing with what? Ribosomes attaching themselves to the what? Smooth, or to the endoplasmic reticulum. So it's easy to become smooth, and now it's called what? Granular, or it's called what? Rough. And that is also involving what? In protein synthesis. Don't forget, translation takes place in the cytoplasm, whilst transcription takes place in the nucleus. Guys, aren't you enjoying these things? Anyway, me, I'm enjoying myself. Maybe it's only me who understand it. But the answer is B. But I believe you understand what I'm saying. But the answer is B. All right. Immune enzyme assay has detected HBs antigen, hepatitis B surface antigen, hepatitis B surface antigen in the blood serum. What disease are you looking at out for? Guys, they've told you. They said hepatitis B surface antigen. What's your answer, guys?
Viral hepatitis B.
Exactly. I don't even know why this is even a question. Your answer is what? Is E. A patient has been diagnosed with gono. Has been diagnosed with gono, as fluoroquinolones are the drugs of choice, yes, for gonorrhea. Which of the following can you prescribe? Which of the following can you prescribe? So we are looking for what? A fluoroquinolone. And the fluoroquinolone you can see here is called ciprofloxacin. So people with gonorrhea, we have to first give them what? Ciprofloxacin. This I don't know how to teach it, but it's a group. Okay, it is a group that you should just know. It's a group that you should just know. So please do well to research on them. Okay. In some books, they will tell you we are having what? A bean-shaped diplococci sort of infection. Is the same thing as what? Gonorrhea. So put it in the back of the head. This is what? A fluoroquinolone. So your answer is what? Is C. Your answer is C. Now, some of you are saying that I should start doing tutorials of maybe pharmacology tutorial. Maybe talk about hypertension. What pharmacological drugs can you give? Maybe heart pathology. What drugs can you give? What is the mechanism of action? What are the contraindications? Some of you are asking me to do some of these things. And I think it's not a bad idea, isn't it? Faustina, is it a bad idea?
No, it isn't, sir.
It isn't a bad idea, yeah. So I'm thinking of considering it. So some of these things, it can become, it can be on our fingertips. But that's what I've done with the Krok. For now, Krok is my primary focus. Now, autopsy of a Middle Eastern woman who had been suffering from wasting fever for a long time. Middle Eastern wasting fever revealed an enlarged blackened liver and the spleen, bone marrow, hyperplastic, black colored, as well. Cerebral cortex was smoky gray. What disease are you looking at for? Guys, what disease is so high that it destroys the liver and the spleen and can even infect or go into the brain and, of course, into the bone marrow? From Middle Eastern Europe, what comes to mind?
Malaria.
Malaria, exactly. So this person is having a very severe malaria. If I will put it, cerebral malaria. We have to call cerebral malaria. And what plasmodium is the most causative for, how do you call it? Cerebral malaria. Cerebral malaria. What plasmodium? Who can tell me?
Malaria.
Anopheles is the female, yes. But what type? We have different type. We have to call the
Malaria.
ovale. We have to call ovale. We have vivax. We have falciparum. What do you think?
Falciparum.
Falciparum. Medicine is sweet, though, guys.
Quali.
Medicine is sweet. So you're talking about the falciparum. Yes, the falciparum. That guy is very troublesome. Very troublesome. So you're looking at what? C as our answer. Falciparum. Now the human red blood cells contain no mitochondria. No mitochondria. What is the main pathway? Now you have no energy. Don't forget, mitochondria is the powerhouse, isn't it? Where energy is produced. Now here, okay, you don't have the powerhouse. So what is the pathway of ATP production? Who can tell me? What is the pathway of ATP production?
Anaerobic glycolysis.
Anaerobic. Anaerobic. Not anaerobic. Aerobic means oxygen. And if it deals with oxygen, you need mitochondria. If you're dealing with oxygen, you need mitochondria. But if you don't deal with oxygen, then you'll be dealing with what? The input of what? The lactic acid. Now you know why people get pain in their muscle, because there's no what? Oxygen there. Mitochondria is not there. So over here, you are thinking more of what? Of anaerobic glycolysis. And of course, glucose that have been broken down is called what? Glycolysis, to produce energy. So you need a lot of what? Carbohydrates. All right. Atria of an experimental animal were super distended with blood, which resulted in a decreased reabsorption of sodium. Decreased reabsorption of sodium. First of all, what cells is able to detect sodium concentration or salt concentration in the kidney? Who can tell me?
Macula densa.
Macula densa, correct for 3 points. Exactly. So macula densa detects some of these things. Okay. But our focus is not on what? On macula densa. Our focus, let's look at it. Now the question is what? There is decreased reabsorption of sodium and water in the renal tubule. Of course, if sodium is not reabsorbed, that means water cannot follow, isn't it? So wherever salt is going, water is following. So if more, now what does it mean by decreased reabsorption? Does that mean that a lot of it is excreted, or a lot of it is, returned to the blood? Who can tell me?
I think a lot of it is excreted.
A lot of it is excreted. Good. A lot of it is what is excreted. So it is excreted with water. Because everywhere salt is, there is water. You can never see anywhere Benjamin is and no woman will not be there. Benjamin, woman will be there. True or false, Benjamin?
True.
True. You see? Guys, I talk calm. I talk calm. So Benjamin, you are salt. So please, take the woman away. But no, today they don't take the woman away. Today I'll be salt. So go your way. Today I'll be salt. You can be potassium, okay? I beg you. All right. So basically, salt and water, they move together. Now, the question that, this can be explained by the influence of which factor? Now, what it means is that, of course, we know macular densa is able to sense these things, but the question is not about macular densa of what can sense it. The question is, what hormone is causing the sodium to be excreted, of course, with water? And the name comes, and of course, the answer is right in the question. The answer is in the question. As simple as that. Now, you and I know that when renin, aldosterone, angiotensin, and vasopressin get activated, what happens? Salt is taken in. True of us?
True.
Yes.
True, yeah.
When macular densa is activated, and then the, how do you call it? Causes the juxta glomerular cells to produce the renin, then the renin will now convert the angiotensinogen to angiotensin 1, and angiotensin 1, with the help of angiotensin converting enzyme, will convert angiotensin 1 to angiotensin 2, and angiotensin 2 will convert the glomerulosa of the adrenal gland to produce the aldosterone, and hence the RAS system. So guys, forget about any one of these things. So over here, we are looking at what? The natriuretic. Natri means sodium. Uretic means water excretion or water. Or sodium in water. Sodium in water. Sodium in water. So it's like after Benjamin has followed or taken all those women, now the other woman will now gang up. O2 and colleagues will now gang up. Today we must deal with this boy. The guy will be there, they will all be with him. So that is what natriuretic hormone for you. They've gone up against Benjamin. So Benjamin, don't do that. Otherwise, they'll gun up against you. So over here, you are dealing with what? The natriuretic hormone, mean sodium excretion hormone. Now, another name for vasopressin is what? What name? It's what? Good. Sometimes I talk plenty, I forget what I'm talking about. It's what? Antidiuretic hormone, AD8. Antidiuretic, that means anti-water hormone or anti-excretion hormone. But this is what? Excretion hormone. And the excretion hormone is what? Is the natriuretic hormone. Again, don't get confused with some of these things. If exam comes and you see questions like this and you don't remember Benjamin, you don't remember how I've been worrying for Stina, how I'm worrying O2 and co. Me, myself, I come to the exam's room, lash you and bring you home. I'll lash you and bring you home. You know what again? I'll bring you home. So your answer is D. Now, a woman gave birth to a stillborn baby with a numerous malformation. Numerous. Numerous. Guys, a second. So, stillborn baby with numerous malformation. So, what it means is that we are going to look for. Have you guys heard of touch infection? Touch infection. Have you guys heard of it? Anyone? Good. Now you heard that touch infection can lead to what we call malformations in children. We call them teratogens. Infection can lead to problems with the babies. So we call it the touch infection. And actually, the touch stands for what? For the diseases that they are. So obviously over here, our diagnosis is what? Is touch infection. Okay. But the question is that what type of touch or which one in the touch is causing, it's a protozoa for it to cause this thing. So first of all, let us analyze the touch just for the benefit of learning, okay? So for the touch infection, the T stands for what? Toxoplasmosis. Toxoplasmosis. So the TO stands for toxoplasmosis. The R refers to what? To rubella. And even in people suffering from rubella, or if you're able to detect that a mother has rubella, we don't even allow the mother to continue the pregnancy. We terminate the pregnancy because the child will die. And even if the child survives, when it comes on earth, Charlie, it's going to be a problem. It's going to be a big, big problem. So we normally terminate the baby, no matter if it's going to be the president or it's going to be the next savior. We don't care. We'll terminate it. I mean, medically. But we all have our beliefs anyways. So, all right, where are we? So, rubella. Then the C stands for what? The cytomegalovirus. Cytomegalovirus. Then the H refers to what? The herpes simplex. Herpes simplex. And these are all congenitally acquired infections that can cause morbidity and mortality in neonates. So, of course, based on what I've mentioned, even if you don't know which one is a protozoa, obviously your answer should be what? Should be toxoplasmosis. And your answer is, sorry, the answer is A, not D. It's a mistake. Your answer is what? Is A. And amoebiasis cannot cause it. Your answer is what? Is A. All right. A 42-year-old patient complains of pain in the epigastrial area. Pain. There is vomiting. There is vomiting. There is what? Masses. Vomit masses have color of coffee grounds. Guys, coffee grounds. The patient suffers from what? Melena. So first of all, this coffee ground means the appearance of red blood cells or blood inside the vomit mass. And the melena means the appearance of what? Blood in the stool. But look at it. They are saying that anamnesis shows what? A gastric ulcer disease. Now, before I continue, who can give me 3 complications of gastric ulcer or peptic ulcer, general peptic ulcer? 3 complications. Quick.
Perforation, penetration,
And what? Bleeding. Good.
Hemorrhage.
So penetration, perforation, and what? And hemorrhage. Another thing that you can think of is stenosis. Especially if the ulcer is occurring at the antrium or the antral part. When I say the antral part, that's close to the pyloric part. You can develop into stenosis. So, of course, you know this differential, this complication in your head. So it helps you with the diagnosis. So the appearance of blood in the vomit and in the feces to tell you that we are having a case of what? Hemorrhagic. Case of hemorrhagic. All right.